for you.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. First, let me thank the organizing committee and the scientific committee for this wonderful invitation. It's been a wonderful meeting, and thank you for staying to the very end. So here are my disclosures. So we'll start off with a case. This is one of my cases, a 87-year-old who came to me with persistent back pain and leg pain. He had tried very different conservative therapies, injections, physical therapy, and he was miserable. And he said that he went to lots of other spine surgeons, and they said, "You're 87. Go home and just be ready to meet your Lord, and there's nothing for us to do." And he wanted to live his life. He rides a motorcycle, he's involved in life, and he wants to continue on with life. And so it's a very difficult situation that sometimes we find ourselves in. You can see here he's got a kyphotic deformity. If you look closer, he's got a mobile spondylolisthesis at L4, L5. If you look even closer, he's got lumbar stenosis at L2-3 and L3-4. So I think a very reasonable question is, should this patient even get surgery, right? One of my former partners, he always says, you know, the first surgery is the first one is elective, and after that, you have no choice. So I think it's very reasonable to think about, you know, should we say no to these types of patients? We have to realize that surgery is traumatic. It's traumatic for our patients, traumatic for their families, their social circle, and even for us as physicians. So why would we even think about doing awake surgery? It's not because the anesthesiologists are lazy. It's that we know that general anesthesia is not benign. We have cardiac complications, we have respiratory complications, we have neurological complications, and then we have the dreaded post-operative nausea and vomiting. How many times we do a T-lift on a patient, their back pain and leg pain is better, but A, they forget who they are, so they have to stay in the hospital till they remember, and they have post-op nausea and vomiting that keeps them in the hospital. They've totally forgotten about their back pain and leg pain. If we look very carefully, this is a study I found out of France. It says that, you know, age is an independent factor for mortality after general anesthesia. So if people that are above 75 years old have a 21 times more rate of mortality after anesthesia. So that's something that we really have to think very carefully about. So this is a meta-analysis, you know, when we started doing awake surgery, looking at, you know, what's out there in the literature. So we looked and we saw that most of the cases were decompression cases. We found that spinal anesthesia patients were interestingly younger but had more comorbidities. And we found some very interesting results. Number one was the spinal anesthesia patients had shorter operative times. And you may ask yourself why that is. For people that are in my operating room, when I do an awake fusion or awake decompression, especially an awake fusion, it's like a F1 motorcycle. You got to have one step after another step after another step because the spinal anesthesia wears off after 3 hours. So your surgery, even the fusion, a T-lift, can't be more than 3 hours. We found that we have decreased blood loss. We think that's mostly because if there's vasoconstriction that happens. We found that they have less hypotension. We know that when people are induced for general anesthesia, they have a hypotension, and so that's very difficult for older patients. We found that, you know, there's less post-op nausea and vomiting. Good things are that they spend less time in the PACU, and they have a decreased length of stay. So that was kind of our first understanding about, you know, awake spine surgery may be a very valuable thing. So we did a few decompressions, and then we started doing fusions. And so I'd like to present this study that just recently published, and this is on awake spine fusion, and this is a matched cohort study. So we took 10 of my patients that had awake spine surgery, and we matched them to patients I also did under general anesthesia. And these were matched for age, BMI, and approach. We found certain things. Number one is 90% of the patients with 1 or 2 level fusions could go home within 24 hours. That's great if you're thinking about moving your practice to an ASC. We also found some very interesting thing. The opioid use was a lot less in these patients that underwent awake spine fusion. We also found I was kind of surprised when the medical student showed me this data, 50% of these patients after a 1 or 2 level fusion took 0 opioids after surgery. So you might think to yourself, why is that the case? The case is because when you're under general anesthesia, you're asleep, and then you wake up, and you're in a lot of pain. And so we're playing catch-up, and so we have to give you opioids and so on to catch up. When you're awake, right, the spinal anesthesia wears off gradually. So you can tell the nurse, hey, I'm having some pain, and we can do other things before we go into opioid use. We also found that those patients under spinal anesthesia ambulated a little bit faster. So this was, I remind you, a matched cohort study. It's not a randomized control study, but it's a pretty good study, a matched cohort in terms of age and BMI. So this is apples to apples. I'd like to argue with you that with awake spine fusion or awake spine surgery, you have a bunch of oranges that you can operate on as well. So this was a case series that we presented of 10 patients who were ASA 3 or 4, and we know that ASA 3 or 4 patients have a very high mortality rate, lots of comorbidities and so on. So the last one here, writing a small 91-year-old patient who came from me from Tennessee. She had a kyphoplasty where they had intubated her, and it took them 5 days to extubate her. But unfortunately, the cement had come into her canal, and she had radiculopathy and so on. And so her original surgeon said, I'm so sorry, I can't do anything for you because it took you 5 days to be extubated the first time. I don't know if you're going to be extubatable. So alhamdulillah, we took her to surgery, awake. We did an awake 1 level of decompression, and we got her out of the hospital within 24 hours. Right? I don't have to deal with post-op nausea and vomiting. I don't have to deal with extubation. I don't have to deal with any of those other headaches. So we talked a little bit now about the benefits of awake spine surgery to avoid the problems of general anesthesia. For the neurosurgeons in the audience, we do awake craniotomies because we want to measure eloquent cortex. As a spine surgeon, there's nothing more eloquent to me than the nerve function. So we also do a subset of surgeries where we don't do a spinal anesthesia, we just do local only. So here's a patient, a very intelligent patient. He designed a lot of the chips on these F-14 fighter flights and so on. He had a L4 to S1 decompression somewhere else, but unfortunately had a recurrent and residual S1 radiculopathy on both sides. He went to lots of other surgeons. They told him, they had done a great job with the laminectomy. There's no choice except to do an A-lift or a T-lift. But he told them, I don't have back pain. Why are you going to do a fusion on me? So for this surgery, we actually do an awake endoscopic decompression with only local. So this is not a spinal, it's just local. So we took him here, we're using this technology that allows us to enter into Camden's triangle very easily. You can see we're entering into Camden's triangle. This is another patient, not the same patient. And I can see where we are, and we're entering into Camden's triangle to do a transforaminal discectomy. So here we are. This is just getting some of that soft tissue off. And here I am opening the foramen, so I'm doing a foraminoplasty. And as I'm doing the foraminoplasty, the patient tells me, my leg pain is better. I couldn't believe it. It's the first time I said, no, you're not telling the truth. But he said, my leg pain's better. So we decompressed a little bit more. We went to the other side. We decompressed the other side. And the same thing on the operating room table. He tells me my leg pain is better. So I know that I've decompressed this patient enough. Now, we don't have to wait for the spinal anesthesia because it's not spinal anesthesia. So basically, we flipped him over. There's no incision. And he went home. And he's actually now a year out, and he's very, very happy. So I think with this local-only protocol, you can really help some patients. So back to our 87-year-old. Just to remind you, big problem. And I was stuck. And for the fellows and the young trainees, I actually have all my fellows call me the night before to talk about cases. I had a great fellow who's now an attending at Columbia. And I was stuck. I said, I can't do 3 levels in 3 hours. And the fellow said, Dr. Abd-El-Barr, why don't we do surgery in parallel? You do the fusion at 4-5, and at the same time, I'll do the decompression at 2-3 and 3-4. So instead of waiting and going in series, we're going to work in parallel. So we published this in parallel technique, and we've actually used it several other times in the meantime. It took a lot of orchestration. We brought in 2 microscopes. Here we're putting in the screws, and you can see here on the left is the fellow, and on the right is me. I'm putting in the fusion. He's doing the decompression. I think this is one of the coolest videos. So on the left side, this is me putting in the trial for the fusion on the left side at the same time that the fellow is doing the decompression at the same time. So we're able to reduce the spondylolisthesis. It's almost percutaneous surgery, so very low blood loss. We're able to do the surgery in just over 2 hours. We have no blood loss, 50 cc blood loss, and this 87-year-old was able to go home post-op day 1, right, with no problems with delirium and all this other stuff that we sometimes have to deal with. This is the paper again. And the best thing is that, 3 months later, he sends me this photo. He's on his motorcycle. I think he's wearing a helmet, I hope. And so we got this 87-year-old back to his original life. So I think that this really shows the power of this type of technique. So just to conclude, I think that awake spine surgery is a very good option for our elderly patients. I think endoscopic techniques are also very powerful. And if you can combine awake and endoscopic, I think you really help these patients. And with that, thank you so much.